Hi, everyone, and welcome to today's presentation, Cost Allocation, Getting the Basics Right. My name is Chloe Setzos, and I am the project coordinator here at Capital Link, and I'd like to thank you all for joining us today. Today's presentation will last 50 minutes with 10 minutes for questions at the end, but feel free to ask questions throughout the presentation in the chat box located in your GoToWebinar toolbar on the right-hand side. A PDF copy of today's slides will also be available for download throughout the handout section of your GoToWebinar toolbar, as well as on our website after this presentation concludes. Jim Maxwell, Director of Research and Policy at JSI, will provide an introduction to the webinar today, followed by David Kleiber, Project Consultant here at Capital Link, and Bob Urquhart, Consultant and retired FQHC CFO, who will review the principles of cost allocation, getting the basics right. With that, I'll turn it over to Jim to get started.
Chloe, thank you. First, I want to thank everyone for participating in this webinar and mention that this will be a series of 4 webinars on cost accounting and related financial management topics. And it's being sponsored by the JSI-led Delta Center for a Thriving Safety Net, which is a Robert Wood Johnson Foundation initiative to advance payment and delivery reform, both in community health centers and in ambulatory behavioral health settings. And we're one of the key impediments or obstacles to moving towards value-based payment and care that we've discovered is a lack of understanding of good cost accounting, and also about and sort of related topics about how you adapt your management operations to operating in a new payment environment. So I wanted to welcome everyone to this first of 4 webinars. And if you want more general information on the Delta Center, please go to the Delta Center at jsi.com for additional information. And I want to hand it back to Dave and thank Capital Link in advance for leading this exciting webinar.
Great. Thanks, Jim. Appreciate that introduction. And I will also extend my welcome to all the attendees. Chloe, you can move the slides along to the first slide, which will go through what the 4 sessions are that we're going to be talking about. So today is the basics, basically, cost allocation. If you follow our webinar series, you might recall several years ago that we did something similar to this as an update to a NAC presentation that they had done way back in 2003 on calculating a cost per visit. So this is might look familiar if you sat through that presentation a while back. We expanded it, and it talks about cost and calculating a cost per patient as well. Then we will transition in February to the second session, which is a much more detailed, granular, how to get your system set up in order to be prepared for that next step of really being able to calculate your costs in a value-based payment world. And so everyone needs that foundation, strong foundation of accounting systems that effectively allow you the tools to move forward. And then we get into sessions 3 and 4, which are kind of the meat of this whole presentation series, but are also where things get a little bit crazier because we all may be exposed to some degree to the value-based payment system now through a shared payment system or something similar. But effectively, whereas we all know what the fee-for-service world looks like, we may not really understand, and maybe nobody understands what a true value-based payment system looks like. So we're going to be charting a little bit of new ground, but it's going to be more important than ever that you understand what your costs are in that world, even compared to the world today. And so those 2 sessions, one will be kind of a discussion of that and some examples of of how that all will work in your world. And then the fourth session will be a continuation of that discussion, also figuring out programmatically how we use this information to benefit us. And specifically, we're going to be doing a lot of discussion about how can we finally use our costs in a sense as a positive in our negotiations with payers, so that we can say, look, in order to achieve the certain outcomes we're after, we incur these certain costs, and we need to be reimbursed for them. And that's going to be the discussion that we lead up to, and that's going to be the discussion that hopefully will get you better reimbursements for your work. All right, so the next slide. All right. So interestingly enough, we live, for the CFOs out in the audience there, we probably think we live in a fairly arcane world of accounting in healthcare, but in fact, some of the greatest business minds on the planet have turned their focus to this particular issue. How do they control costs in healthcare, and how do we track costs in healthcare? And Michael Porter, who's many of you may have heard of from Harvard University, has done a lot of work in this space, along with Robert Kaplan, who's both of them are eminent economists there. And so it's kind of interesting to see their view. And it's pretty, this is pretty cold that they're basically saying that we are way behind the rest of the industries in figuring out how cost accounting can be used in our industry. We all know about our financial accounting. We provide our boards with financial statements, income statements, balance sheets, cash flow statements. But very few of us, I'm guessing, actually drill down on the cost basis of our services we provide. Do we really know what it costs to provide our services? So next slide. But it's not going to be easy. And part of the reason it's not easy is that healthcare as a service business is not particularly amenable to cost accounting techniques. And the reason for that, I mean, you can imagine if you're a widget maker, making a widget, the cost of the materials that go into it, then the process line and the cost of the labor to get it through the process, and then sales, that's all fairly straightforward. But the problem is, and this is, again, in a different publication, Porter commenting, is that we've built a primary care system that is fairly one-size-fits-all. I'm sure many of you are thinking, oh, no, ours is not that way. But overall, the primary care system doesn't really know necessarily what that next patient is going to approach with. So we have this one-size-fits-all mentality, but we have a very heterogeneous patient base. And so that results in one conundrum that we'll talk about throughout these four presentations, and that is that each of these patients, we would love to be able to put them into a bucket and cost that bucket in order to understand whether we're getting reimbursed enough. But effectively, if we drill down far enough, if we have 1,000 patients, we have 1,000 cost buckets, and that's untenable, right? We can't be tracking 1,000 cost buckets. So at some point, we need to be able to put people into groups, even though they arrive with heterogeneous conditions and needs. Okay, next slide. But as this is a slide taken from the presentation we did 2 years ago, because it's still very much true. Some things never change. In order for you to really successfully manage your health center, you have to know what your costs are. You have to be able to track them, allocate them, and compare them. And this presentation will do some of all of that on the cost per visit and cost per patient basis. And we'll talk throughout how this is going to change in the value-based payment system, whether it's global payments or population payments or ACO, shared saving, whatever. It's going to change a little bit, but we need this foundation in order to be able to understand what those changes are. Okay, Chloe, you want to move on? Unfortunately, that transition is not straightforward. So this is kind of a graphic slide just to give us a sense that, in fact, we don't. It isn't. Whereas cost per visit to cost per patient is really straightforward. The transition from those two to paying for outcomes is going to be not so linear. And that's going to be where it's going to take some work on each of your parts. It's going to take some decision making as to what part of that value-based payment systems we're going to adopt and try to cost out. Because the truth of the matter is that many bright minds and many huge hospital systems have been diving into cost per value-based payments, outcome costing. And very, very few, if any, have have actually instituted this system-wide. And so they've cherry-picked to some extent. They found where their most needy patients are, their most costly patients, and they've spent their time costing there. So that's kind of going to be the general approach. But in the meantime, we're going to dive into what it means to analyze and develop your cost per patient, cost per visit. So the next slide, and with the next slide, I'll be handing. This is if you're interested in more detail than we provide here in this webinar, then you can go to our website and it's free for downloading this presentation from several years ago, which was the update to the NAC 2003 presentation on cost per visit. So it's more detailed in there if any of this gets by you or you have questions. Of course, you're always welcome at the end and throughout this presentation to indicate your questions to us, and we'll try to answer them as best as we can now or at the end of the presentation. But you always have this resource available to you as well. So moving on from that to the next slide, I'm going to hand this over to Bob. Bob Urquhart has 20 years of experience in just health center CFO, but before that, he worked in retail and as an accountant and a CFO in retail. So it's that dichotomy of experience, I think, that is what made him so valuable where he was at Greater Lawrence Family Health Center in Massachusetts. And I'll let you decide, after listening to Bob, I'll let you decide which of us comes from Massachusetts. Go ahead, Bob.
That's going to be pretty easy, Dave, right? Good afternoon, everybody. I'm very happy to be involved in this. It's an exciting topic and one that I enjoy talking about. On the slide, you can see that the components of cost per visit or patient are pretty much straightforward, I think, and I don't think I'm telling you anything you probably don't already know or aren't somewhat aware of. But direct provider cost, the cost of the provider in the room, direct support costs, all the people that are involved in delivering the care or the visit that day to that patient, the enabling costs, the things that are somewhat different than, the nursing and needles and that sort of stuff. Overhead is probably one of the biggest topics. It's all of the costs for patient accounts and finance and systems, whatever. How do we allocate those costs? First of all, track them, and how do we allocate them on a cost per visit basis? And then ancillary and other costs for those health centers that have them. And this would include some things that I've only run across a couple of health centers that actually have those things in their environment. So we'll talk about each one of these in a little bit more detail as we go through. So provider cost visit, basically saying how many providers are in the rooms, in the exam room or in the exam rooms in your clinic, providing care on that given day. So it's the total salaries, includes all of their hours and all of the types of hours, total salaries, total benefits. What is it, the personnel salary cost for the provider in the room delivering the visit? The example we have on the chart shows you the 8 physicians and the $1,004,000 and $280,000 in fringe. So basically, if you take that as 25,000 visits, you get $67 a visit. Pretty straightforward example, but this is just probably the most simple way to capture a provider cost per visit. You go to the next slide, you get into what makes up that cost: compensation, productivity, non-clinical activities. Compensation, obviously, is the direct salaries, and depending upon what your health center does, do you have a compensation plan that has any kind of additional payments for productivity-based systems, RVU-based systems, non-clinical activities? Do you have clinicians that are doing things that are doing precepting, hospital rounding, things outside of your clinic? And then what kind of providers do you have? Do you have all family practice providers? Do you have a mix? The health center I worked at, we had family practice docs, we had geriatricians, pediatrics. So we had a pretty good mix. And we were a fairly large health center. We had 280,000 visits a year, and we had 110, give or take, providers. Head count and 60 FTEs in round numbers. So these things are what factor into that. What is that provider cost per visit?
And going back to that last slide for a second, Chloe, we will be talking about, and keep in the back of your mind that, in fact, outcomes at some point may be added to this list. And think about how that might work in team medicine. you could see where it might not just be a provider in a room with some indirect help from nurses and MAs, and then some perhaps a visit to the lab. It could become much more complex than that. So that's just kind of a sneak peek at sessions 3 and 4 in this series. Okay, next slide. Thanks.
So I think this is information that David kind of gathered to basically just give us an idea of what the compensation looks like for health center providers and physicians in private practice. This is kind of more for information only. It might be different for all of you, obviously, but it's kind of a benchmark. And just as a general comment, a lot of stuff we're going to show you today and in future sessions, they're meant to be thought-provoking or to give you some sense of what these things look like across the board, but they're not meant to be your benchmark or things you have to do. These are just things that we've been able to find in our travels, and some of it is on first-hand knowledge, but this is just basically some information that we thought might be useful.
Right, and along those same lines, you can see that those numbers there's quite a bit of difference between the FQHC world and the private practice physician world. That doesn't necessarily, if anything, it makes your job and we all know it's difficult already, of finding those provider FTEs to fill in the slots to generate the visits, in the future to generate those patient outcomes. Makes it even more difficult. But you also noticed quite off the bat that these are large numbers, most of them. And so these are, clearly going to be your major costs in any kind of system in which you're trying to figure out the cost per visit or patient. It's going to be these folks. But as Bob said, use these numbers a bit as a reference from a national perspective. They come off the NAC salary survey and off of the Medscape compensation report. So they're real numbers and they're recent numbers, and they might be of use to you on that basis. Okay, next slide, Chloe.
So on the provider cost per visit and patient compensation, the list below is some of the things that some health centers do, some do now, some have to think about doing. But is there a productivity component? Is it a patient and member satisfaction component? Quality, which a lot of health centers are now currently doing. Effectiveness of managed utilization, peer review, compliance with health centers policies, what we call citizenship, where I was working. And also some of the health centers, and we use them a little bit, are using relative value units as part of the compensation to try to balance the playing field, in the sense that you might have one provider who is in the acute care setting and he or she is doing 4 or 5 visits an hour because it's flus and colds and sniffles and they're in and out, and you have the pediatrician or the geriatrician who is taking a half hour, 40 minutes for the patient. So using the RVUs, we found help balance the field a little bit. But these are just kind of some things that, if you're not already thinking about them in terms of compensation, you might want to. And I think particularly with the quality outcomes, that it's not widely used now, but it is used. I know at least 7 health centers in Massachusetts use a lot of it. But I think as we go to pay for outcomes, that might become a bigger part of this.
Well, and I think that adding, you can almost put another dot at the bottom there, Bob, and add, quality and outcomes to this list, because, that if you're going to get paid based on outcomes and the value you create for both the system and the patient, then obviously we need to make that part of how we compensate the provider and everyone else on their team as well. So that's going to be a change that we can definitely see forward. And on your comment about RVUs, I think we're all familiar with RVUs. It would be interesting. I know sometimes we could do these. It's not only semi-relevant here, but you could do a survey and find out how many of you out in this audience right now are aware of RVUs. I'd suggest that number is very high. But how many actually use RVUs? Bob, in your experience, I think it's fairly limited, but that's generally kind of where we're going in a sense. It certainly has value in the name. It'll be interesting to see how the techniques that were developed in the development of the RVU system carry over to a value-based system of payment. Go ahead.
I think that's a good point. I think, as I said, the health centers I've worked with over the years in Massachusetts, even some of these folks I've had at NAC, RVUs was something that was kind of floating out there. Everybody knew they were there. Some people used them, some people didn't. Some people used them selectively. We started out using them, when I say we, my former health center, started out using them in a very minor way, but then we found out that it was really a nice way to take away some of the, I don't think it's fair that DocX is getting all these compensation for productivity. I can't do that because my patients take more time. And so we said, okay, well, let's go find that out. And we did. And I think to the extent that it made sense, we used them across the board. But to Dave's point on the quality and outcomes, we measure quality now. There are some HEDIS measures that we use at health centers that I've talked to. But I think it's going to be that plus more concrete outcomes in the next 3 to 5 years if things continue going the way they're going. That makes sense, Dave?
Absolutely. Next slide, Chloe.
And so some of the other things to think about for the provider cost and patient non-billable factors. Now, there's a lot of work that gets done that no one pays for. How long is a clinician and provider session? What's the number of sessions that they do during a week? On-call visits. Do you have a system where providers have to be available for nights and weekends? Most health centers, would be closed after 5 or 6 o'clock. Some might stay open later. My former health center was open till 9 every night, and part of the days on Saturdays, Sundays. And we did have on-call teams because we had hospital responsibilities. So, what are these other non-billable factors that we're paying the provider to do a lot of work, including these things that theoretically no one pays for, if that makes sense. Okay, next slide.
So here all we're really doing is kind of putting some of that into a table. So on that first line you'll see it's a comparison of what your advanced practice practitioners, providers, are being paid versus what the average family physician is being paid. And again, that comes out of the salary survey, so we didn't make these numbers up. But you can see that clearly it's only 50% roughly of their pay, but their productivity is substantially higher. not higher. The family practice physician is higher, but the percentage of the APP's productivity as compared to the physician is much higher than what their percentage of pay, if I'm saying that correctly. So it kind of it's an easy conclusion here that to some extent, if you want to you may be driven in your practice to save money or to lower costs to hire more of those APPs. Now, in behavioral health, there is a similar transaction going on with or relationship, I should say, with psychiatric nurse practitioners whose average 2020 salary is $120,000, compared to psychiatrists, which can be closer to, I'd have to go back a couple of slides, but it's in the high 200,000s, might even be low 300,000s in certain parts of the country. So it's easy to see the salary piece. What we don't have from the UDS, because it's not tracked, is what the productivity of those psychiatric nurse practitioners are. So we can't quite do the same analysis as this, but I think it'd be a safe bet that this same relationship probably holds in that world as well. So clearly your staffing mix can be impacted by the costs and the productivity overlay. Okay, next slide. Here we're walking through the same kind of transaction. It's just, we made up something called the Eastside Health Center here, put some data in how many FTEs they have in these various provider types. Then we took the salary costs roughly from the salary survey, and we made up some visits and the like, and came up with a cost per visit over on the right-hand side and a total at the bottom right-hand corner. And all this is trying to do is suggest something or to illustrate something that you're also all very, very aware of, which is, if we, in a fee-for-service world, if we increase productivity, we make money, right? I mean, we generate more cash is a better way to say it. It doesn't necessarily mean we're going to make money in the sense of profitability, but we're certainly going to generate more cash. And at the bottom, you'll see in that little blurb there that by increasing 15%, your productivity 15% across the board in this particular example, you effectively generate, you drop your cost of per visit from $63.47 in that bottom right-hand corner to $55.19. And that's the equivalent of $250,000 that now can be used perhaps in part of an incentive plan for those providers to get them to increase their productivity. And we know, in our conversations with health centers, it's always, this is basically the world we live in, right? It's how to make, whether through it's the design of your clinic or your programmatic choices or how much staffing, which we'll talk about here in a minute, you provide them, how much support, et cetera, how can you get that productivity to rise? That whole effort may change in the future with a value-based pay system. Some of us, to our relief, if we can finally lay off our providers a little bit. But right now, in the world we live in, this is the mathematical reality. Bob, any comments here? Otherwise, we can move on.
That's true. I think that it's a matter of in the fee-for-service world, the more patients you see, the more revenue you generate. For the provider, if they're on a compensation plan that recognizes that, the more they can make. But it's like you're on a treadmill and you just keep running. And that's how the providers feel about it. So yeah, I think that's true.
Great. Next slide.
All right. So after the direct provider cost, which we kind of walked through, the next big piece to the cost per visit or per patient is a support cost. What are the costs associated with having the nurses, RNs, LPNs, medical assistants, receptionists, registration, all those people that the way I try to look at it is the people who are involved in delivering that visit that day. And they're in the room, they're doing something. So it could be, if you have dental, it could be dental support people. If you have mental health support people, and the cost of other things like medical supplies, cost of vaccines, all of the things that happen that other than the provider were done by this group of people. These other things are now captured and are included in your cost per visit. And then we've kind of put a graph together that shows the same thing on direct support staff. If you had dental assistants and technicians and what their combined salaries would be, what their fringe would be, and then the cost of dental supplies. So you have $454,000 for 7,500 dental visits, or $61 a visit. Now, dental supplies is one piece. There could be other things too that are in there. Could be other medical supplies, but when we talk in session 2, we talk about, we will be talking about how to capture this kind of cost information at a much more detailed or granular level maybe than you used to. And that's where you'll see all these other things besides the major ones you can think of off the top of your head.
And if we move these slides along a little too fast, again, I'll refer you back to the publication that's available on our website, where this is all detailed. You can spend as much time as you want on it. In the little shaded box down below, it just has the very straightforward cost per patient. We made up a patient number that goes with these visits, and you can see that we're $61 roughly a visit. It's $152 per patient. So clearly, depending on how you get paid, you're interested in the visit if you're being paid on a per visit basis. If you're on a capitated system, then you're more interested in the patient number down below. But in either case, the math is fairly straightforward. Next slide.
So when you look at the same kind of thing, it's what's the compensation, what's the productivity of this group, what's the staffing mix, do you have more MAs or nurses? There are many different thoughts on that, and you talk to different health centers. Some say nurses can do more, so therefore you have more of those, but they're more expensive. Nurses, in our experience up around here, can bill for about 50% of the work that they do. The payers haven't quite caught up to the fact yet that nurses can provide a lot of services at a lower rate than a provider can, a doctor physician can. So if you have a staffing mix, you got to think about what is that mix going to be, and then how many support staff do you have in providers? What's the right number? And some of it gets decided on not necessarily what's the right number based on a provider's thought process or a support staff, but based on what the numbers say. What can you afford to have? For example, in my environment, we provided 2.5 FTEs of support staff, which was registration, nurses, MAs, and other people delivering care to every full-time FTE in the clinic. And then we did our budgets and ran all our numbers that way. So there's a couple of things you have to think about in looking at that.
Well, and this is going back for just a half a second there, that this also adds into the whole idea of this graph looks very familiar to what you saw from the provider point of view. But in the event, and having worked in many of the 50 states, there are some places where nurses can be reimbursed, where nurses can do triage visits and actually get paid. And if a nurse can't get paid, then unfortunately you also have to look at it and say, okay, if I've got a patient in the waiting room who could be triaged by a nurse and actually, treated in some extent, but they're going to walk out and I don't get paid, then that impacts your decision making, right or wrong. It's just the way of the world, right? So that's where your individual situation and your individual state may change a little bit and impact how you look at those MAs and nurses and those indirect staffing, and to what extent you can get some reimbursement for them through some program. But in the future, again, just kind of giving us a little sneak peek, that nurse, advanced practice nurse, possibly, or a LPN or somebody like that, in a team medicine context, in a room with a chronic patient, let's say, could be part of a cost which you can get reimbursed for. So that would be part of the reason to keep an eye on those costs and be able to allocate them correctly. Okay, next slide. So these are the numbers off the 2018 UDS, and we provide them to you just to give you some sense. So let's put Bob's number in context here. So he just threw out he had 2.5 at his health center, FTE medical support. Now notice this is UDS numbers, so this does not include your lab and X-ray. This is just your nurses and medical assistants and other medical personnel over the number of medical providers you have. So 1.75 is the overall national average, which, granted, at such a high level may or may not be particularly relevant. But what is interesting is that the next two numbers are broken down. So we took all of those numbers and divided all the health centers by productivity on a visit basis. And so at the 75th percentile for productivity, those centers, we did the calculation, have 1.97 direct support staff per provider, whereas at the 25th percentile, it's 1.47. So, the difference there is exactly half an FTE, but at the same time, it's clear and it's statistically significant enough to suggest that if you can afford it, more provider staff is going to be better for your productivity. But as Bob mentioned, and he's probably got a million examples of this, that alone can't drive your decision making, because it really depends on how much it costs for you to put that person in, the extra person on your staff, and how many visits you generate, so that additional productivity, how much more revenue does that actually generate? And you also see the same numbers.
It's
similar
an
numbers
interesting
now.
thing.
Yeah, go ahead.
One of the interesting things we found in this over time is we experimented with this a lot, and there is a number of support staff people that the providers actually said there's too many people, it's too confusing, it's like a fire drill in the room, we can't have that. Because we actually had 3.5 or 4 to 1, then 3.75 to 1, then 3 to 1, and then the finance numbers took over, and it became too costly to have that kind of system. So we ended up we settled on 2.5 to 1. It helped us achieve our productivity goals, but it was interesting to get the feedback from the providers and the people working in the clinic that you get to a certain number where there's too many people. So you got to find that happy spot, if you will, that gets the work done, people feel comfortable with what they're doing, and you can afford to do it.
That's great. Next slide.
All right, so direct enabling costs, some of these, they don't all apply, but, case management, you can kind of read the list. I won't go through every one of them, but I think that these are things that you have to be able to capture, you have to be able to put value on and include in your financial analysis, keeping in mind that a lot of stuff that's on here is not necessarily reimbursable. People don't, generally speaking, you're not going to get paid for transportation from Blue Cross or from Medicaid or anybody like that. You might get a grant to help you with that, but at the end of the day, these are costs that you have to be able to capture and say that in order to see that patient and provide them the care they needed, these are the kind of things that we had to do. So to the extent that you do these things, you have to be able to capture them and be able to report them.
And to Bob's point, this is really maybe the most important slide on some level in relation to our future conversations in this presentation series. And that is that all of you probably would love to offer every single one of these, but you constrained because you're not reimbursed for 99% of this. Perhaps you have a grant program that has bought you a van or, does some case management for you. That's all great. But, we all know that isn't necessarily consistent. And if you can't bill it on a per visit basis, it become problematic. But in the future, if you can imagine a future where you're approaching your payer and saying, all right, the game's changed. We're going to be paid by outcomes. We can demonstrate clinically that our outcomes are dependent on us being able to offer some of these services, whether it's, social determinants of health related, transportation, translation, whatever. Those costs can be kind of lumped in. And this is where being able to, prove that in fact those costs are in there and not just kind of winging it and saying, well, of course these people cost money, but you actually come to a number and you can demonstrate what that cost per visit is, or that cost for the outcome that they want is, then you could potentially get these costs into your reimbursement. And that's the holy grail. That's the home run, if you will, of where this system might be evolving. Next slide.
I just want to say one thing. As we're going through this, the questions that are coming up on the screen we're looking at, and if they're just as a general rule, if we can answer them, pretty straightforwardly and pretty quickly, we'll try to do that. If not, we'll circle back at the end. But one of them that popped up that caught my attention on this whole support staff ratio is interesting. That the synopsis of the question was, what do you do first? Do you add all the support staff and give them providers and then see how that works out? Or do you have the providers stress their productivity to pay for the support staff? The answer in my world was we made the providers prove that they needed the support staff by their productivity measures and that sort of thing. So I would answer that question by saying it's probably a little bit of both. You have to have some basic support, and then whether you add or don't add will depend on, for example, we had one provider who could do 4.5 patients an hour because the guy was just great. We had others who could do 1.5. The one who do 4.5, we gave him an extra MA because it paid for itself in the sense that he was doing almost 2 patients per hour higher than our clinical average. So I think the answer is, yeah, you try to stress the provider to earn the support staff, if that makes sense. Okay, so if we'll move on to overhead cost per visit. These are the things that unnecessarily you have to do if we're happening in the clinic, but this is the rent for the building or the mortgage for the building, depreciation costs of the equipment, facilities costs, administrative costs like patient accounts and IT and all those people that are providing services that are necessary to provide patient care. And then to be able to track all of these in cost centers and to know what those actually are and get those included in your cost per visit, because without that, you do have to pay rent on the building. You do have to pay for the staff and facility staff. You do have to pay for insurance and all the things you see on this list, among others. So this all has to be factored into your cost per visit, because when you're looking at what do you want to negotiate for rates, you got to make sure it's an all-in calculation, because you can't just say, well, it's whatever just the cost of the clinic is. It's all these other things as well.
And to add to that, there's that thought, at least it's not listed here, but maybe you could put it into the last one, is that, remember, you're not a break-even. Your goal is not to break even. I mean, that you settle to break even overall, but your goal is to make a little bit of a margin, because that's what builds up your cash reserves in order to go on and expand. That's what allows you the cash reserves in order to, when you have a payment interruption for possibly a political reason, we've all lived through those. You got to think that way. I mean, you're a nonprofit, but you still need to try to generate a profit. So putting some percentage into this calculation for return on, some positive return is okay. Don't reject that because you're a nonprofit and you're just after a zero-based budget. Okay, next slide.
Exactly. And one of the things a quote that I'll share with the group that I'm stealing from someone from NAC, basically said that we need to look at it this way. Nonprofit is a tax status, not a business objective. So if we want to invest in future services, if we want to have more support staff, if we want to give our existing staff raises, if we want to do some other things, you have to have a surplus. So in my former health center, we would do our budget, and we had a threshold that said we had to have at least a 3% surplus in our operating budget before it could be approved by the board. And then we managed to that, because you do have to have some money left over to do some of the things you want to do, or to handle things that you didn't expect. So the thought process is you have to run the health centers like a business. You do have to have something left over at the end to do other things with.
Great. Next slide.
So I think that, this, again, we're just talking about the same thing. If you consider that in the health center world, and I'm sure all of you experience this, the single biggest expenses is personnel related, is salaries and fringe. Probably 75 to 80% of most places, between 70 and 85%. I've seen it as high as 85. I've seen it as low as 70. Where I came from was right around 80. So when you want to make changes and you want to improve and reduce your costs, there aren't too many places you can go other than looking at what are your ratios and what are your overhead costs per visit in terms of salaries. And usually it's looking at the overhead centers, I mean the non-profit share, if you want to look at it that way. So we spend a lot of time looking at productivity, looking at staffing and administrative side. What do you do for billing? Do you outsource some of it or not? So these are the kind of things that I think you want to make sure that when you're looking at your cost per visit, you're taking these into account.
Yeah, that's exactly right, and it may change a bit in a value-based system, but we're making this march towards cost for value-based system and cost per outcome, along with the entire hospital system in the United States, because that's where most of the research is being done. And their world is different than ours. They're much more capital intensive than we are. So that overhead allocation to their world is a slightly different calculation than ours. The fundamentals are the same, but the impact is a little bit different. So I'll just echo Bob's point that effectively, if you need to reduce costs, it's pretty clear where you have to go. The question is how you approach that. I'll let you go ahead with the ancillary costs. Now we're on this next slide.
So the ancillary costs, I mean, to the extent that health centers have them, and I don't know in our audience how many deal with this, like radiology, lab work. Most of the health centers that I've worked with in Massachusetts and some that I've worked with nationally, like labs are usually outsourced. Whether you refer the patient to a Quest lab or a diagnostic lab. In the health center I worked at, we had lab on site, but it was run by our hospital partner. We donated the space to them. They brought the phlebotomist and they paid for all the supplies and all the drawers and everything else. And they did all the billing, all the collections. So we looked at that as a win in the sense that, we gave up, 80 square feet to them to have a room to do the work in, but we also avoided all the costs associated with trying to do it ourselves. We ran 3 or 4 different analyses to say whether we should bring in-house or not. We can never find a way that it made sense. So to the extent that you have them, these things, radiology, laboratory, or other things, you do have to make sure you can calculate those and include them in your overall costs.
That's a really great point, Bob, and I think we can only emphasize the fact that you don't want to. It's why we carved this out. Ancillary costs and pharmacy, which now is its own little world too, but wasn't always the case. You want to carve those out because you may have an overall medical cost and think, wow, we're losing money on a per visit basis, when we don't know why. And it may be that the visit itself is fine, but you've got this lab or X-ray cost that you're just carrying forward, but there's not enough patient volume through it to actually justify its existence in-house, whereas you have an option to do it outside. So that's where that being able to break these things out and look at them on a cost basis can help you with your decision making. And finally, I'll just note in the bottom again, in the pay for outcomes world, if, for instance, you have a big diabetic program, clinical program, and as part of that, they need to have their blood drawn regularly. Right now it's kind of a separate transaction that you get paid for, or the lab you send them to gets paid for. But if you can lump those costs in, identify them, and lump them costs into what we're going to be talking about in future sessions as a clinical pathway, and a group of services required to achieve an outcome, then you potentially can break down that barrier and make some money on this, or at least recover your costs. Okay, next.
Before there are a couple of questions I'll answer in general. One of them is related to overhead, and there's a specific list on overhead. And what we're showing you are some just examples. There are other things. What we can do after this is over is get you a more detailed list. And I think also in session 2, you'll see a lot more detail around those, which I think will be helpful for those of you that hopefully listen to session 2. And then I think that one of the questions has to relate to office supplies, and do include that in the direct support cost. That's meant to include the salaries of the nurses and all those people, and medical supplies, and office supplies, and any other cleaning supplies, anything that was done specifically in that clinic to support the business being done there. So yes, you would include that, and we'll see that in session 2. We have a little breakout of what that chart of accounts would look like.
Yeah. So I mean, we don't spend a lot of time here. Go ahead, Bob.
Yeah, but in follow-up to what we just talked about, the question is, do you do them or do you not do them? If you do them on site, yeah, you have to be able to track them and report them in a section because it's important to have that cost. If you don't have them, if you outsource them, you can make an argument there's a cost for the room or whatever, but we always found that we were significantly better off letting them do it versus us. We save money by doing it. So I think that the summary here is basically understanding what you do and don't have, and then being able to capture the cost related to it.
Yeah, and again, it's about a unique service that's and we talk about it in these next 2 slides. Thanks, Chloe. That's just where we want to be. The next 2 slides we'll go through quickly. A lot of numbers. You can see this exact calculation in the publication, and it walks you through step by step how to get that lab cost in this case, and ancillary service, how to calculate them and how to allocate the costs. And we're not going to go through it in detail, but it does give you a sense that, all right, here's a unique service which we can cost down to the dollar and get a much better, very clear out understanding. Does this make sense for us to be doing? Are we getting reimbursed adequately for it? So, Bob, I don't think we need to go through this in detail. You can click onto the next slide.
No, I think this would be a nice segue to session 2, because we do talk about a little bit more about how to get this stuff.
Sure.
Okay.
Chloe, you can move on. Thank you. So you can see that the only thing I'd point out here is at the bottom, you don't want to take, you can see where we came up with a total cost for the lab of $470,000, and you have total healthcare visits of $32,000, but that resulting $14.47 is not the number you really want to be focused on, because that includes visits that had no chance of really utilizing this service. So you got to make sure that you're looking at it and saying, all right, how many lab procedures did we do? Then it comes at $22,000. Well, then now we have a cost of $21.38 in this just made-up example. So that's the number that's much more important to you from a reimbursement perspective. Are we covering that cost? Okay, next slide.
Exactly.
And here is just, we're not going to go into the detail here. This is, if you're interested nationally, this is how the numbers break down. So we walk through direct, enabling, indirect, lab, and what these are the numbers that come out by the various service lines. So on a per visit and a per patient basis. So we're not going to, it's a lot of detail here. I apologize, it's kind of small font, but if you're interested, this is not in the publication because this is 2018 data, so might or might not be useful to you, but you can see that, on the whole, the medical costs for a given visit in the U.S. FQHC system is $219. It's, how many of you have a PPS rate that's $219? So, you just got to look at it and say, okay, obviously we're getting some grant support for our uninsured patients, et cetera. But, that's not a bad benchmark, or something like it on your state basis or more locally to be comparing yourself to, and benchmark is important. Okay. We're running a little bit out of time, so we only have a few slides left. But, here's some, in conclusion, before we get to general questions. This is pretty obvious, right? But in a fee-for-service world, more productivity rules. More visits is more money, and so the revenue, productivity is your revenue model driver. In a capitated system, not so much, right? Because now you don't want to see more visits from that patient. You want to actually see fewer patients from that visit. You want more patients. So that's a fundamental change in how we view our kind of outreach and how we're serving people. And now take that understanding and put it into what you now understand to be a value-based system that's coming. It's like, okay, if I got a patient who comes in and they've got the classic runny nose, or they got food poisoning or something, it's a one-time event. It's an episodic care, if you call it, and we can solve that and move on. But if I've got a complicated patient and I'm being paid to keep that patient stable in a sense, whether they're asthmatics or they're diabetics, then it's a different world. Next slide. There we're going to be looking at how do we keep that patient reporting outcomes that we've been told we need to get to in order to get rewarded in our quality of care and outcome measures? And that's a different change, right? I mean, it may mean we have to relook at the care team, which means that the productivity could fall, but our reimbursement rate actually, our total reimbursement, patient-driven revenue rises because we're hitting our quality measures. But as we'll say over and over again, a lot depends on how much of a reward are you getting. Is all your reimbursement going to be based on how you do in that value-based world? In other words, if you don't hit that outcome, do you get nothing? That's not likely, but it could be the case. So this is why this brave new world we're entering really needs to be understood, and we need to approach it with all our cost data in hand. We need the ability to be able to say, okay, I can adapt to that. I can adapt my systems, and I can, you tell me how I'm going to be paid, and I can decide whether that makes sense for me. And in those initial years, initial negotiations, I come into those negotiations armed with the data I need. Next slide. Okay, Bob, I'll let you take over here.
So I think some of the things that we need to talk about and that we will continue to talk about as we go through these sessions, why do we get the basics wrong sometimes? I think not having a very detailed shot of accounts to capture what we need to capture by site, by department, by program, it's difficult to get a true cost of things if you're not actually tracking it. So we will have to talk about with you in the next couple of sessions, how do you get to that level of detail? Using the EHR and practice management system to track down denials and some of the other adjustments that affect the finances. For example, denial is not just losing the revenue side, but denial also has a cost associated with it. A front-end registration issue that a patient doesn't get registered properly, and you have to do this extra work. It means you probably have more staff because you have a high level of denials or a high level of exceptions. So how do you manage that and track that? And the HR system and payroll system, being able to track hours and by cost center, by department, by program, becomes important. Some of the stuff we showed you in very general terms earlier on how to look at hour ratios and things like that. There's even more detail that we'll show you in the next couple of sessions what you need to have that information to do. That being said, it's not necessarily all about our systems. A lot of it has to do with how do we view our environment. For example, grants don't cover our overhead, so we don't fully allocate. My advice to all of you is that regardless whether a grant is going to pay for something or not, if that expenditure is related to that grant activity, you have to charge it there, put it into that grant cost center. And then if it turns out that grant runs a deficit, you now have a decision to make. Do we continue to provide that service even though it doesn't cover, the costs don't get covered by revenue or payment somewhere? And if we do decide to do it, everyone knows, okay, that the investment in CSS is $400,000 a year and we're willing to take that on. The other issue then is how many patients does it keep? If the funding's gone away, can we afford to continue doing this? These become pretty hard business decisions for health centers because, we're mission driven and it's but you have to have a balance between mission and margin. You probably all heard that. But the fact of the matter is it does come down to utilizing all the information we have and then making wise decisions with the data that we have.
That's it. And so we're looking at a conclusion, looking towards the future. We're still in a fee-for-service and capitated environment largely. I mean, and that we could go back in the time machine 3 or 4 or 5 years ago, and the same slide could have been put up. Right? We've been talking about this transition to ACO, shared savings, pay-for-performance, bundle payment, whatever you want to call it. We've been talking about it for a long time. And the good news on some level is that it is starting to happen. The bad news, of course, is that it still seems like on many levels a glacial pace. This is across the whole, there seems to be enough momentum across the entire healthcare world, A, to save money, and B, to improve outcomes, that these changes are occurring. But as we're going to talk about in the next couple of sessions, those incentives for A, lowering costs, and B, to increase outcomes don't necessarily drive you in the same direction. So you need to become a strong advocate for, and you do this in your payment negotiations, for your own centers and your own costs to make sure they're covered in that world, that you're producing the outcomes they want, but you're actually getting compensated for it. Next slide. So the hybrid world we live in now obviously complicates things, but we will be transitioning. I think we have to make that assumption. There's almost no choice. I saw a graph the other day showing the productivity since 2011 by FQHCs, by both providers and mid-levels, and it's a stunning negative trend line, right? For whatever reason, EHRs, team medicine, call it whatever you want, has resulted in a very, very linear decline. This is through rural centers and urban centers. It's a declining productivity. So if we're going to hitch our wagon to the fee-for-service world, the outcome for that, or the outlook for that, is not all that positive. So we don't necessarily want to look towards this value-based world as a value-based payment world future as a threat. I think it's an opportunity for us, so that we just need to be, cognizant of it, think it through. Next slide. And so here's what the sneak peek is. We're going to be talking about value. So you got, health outcomes achieved per dollar spent. That's a pretty standard, and we're back to Michael Porter again. That's fairly standard as to how you would calculate what value is. But okay, think about it in a couple different ways. What's a health outcome to you when you're a patient in your provider's office, right? And then what's the health outcome mean to the provider? And then what does a health outcome mean to the payer? Those three may not all line up to be the exact same answer, and that's important to understand. But it is important that we get away from an input-driven calculus, because that's where we are now, right? Our costs are all about inputs. If we can demonstrate that we input something, which we call a visit, which we call services provided, we get paid for it. In the future world, it's about outcomes. That's the opposite of inputs on some level, right? It's fundamentally different. If you put in all these inputs but don't achieve the outcome that they're after, you may not get your costs back. So that's very important. Next slide. So again, the other difference is that cost, which seems understandable on many levels to us, almost inherently understandable, and we've been going through this whole session just to talk about it, we can identify now the cost of that visit pretty closely. And again, Bob will say this many times going forward, we don't want to make the perfect enemy the good. It doesn't have to go down to the cents level. You just have to have a pretty close idea of what your cost per visit or per patient is. But that may change in the world. It may in the future. It may be about the full cycle of care. We're costing how to get to those outcomes, not just the cost of that particular intervention on any given day. So that's where things are going to change, and that's why we're hoping, next slide please, we're hoping that we can entice you to come to the next one of these sessions, which will be held on February 18th. And this is where, I've been thinking about this. Is kind of, I feel like Alex Trebek to some extent on Jeopardy, and Bob is basically the Ken Jennings, or one of these guys who knows everything. So the next one is going to be largely driven by Bob and his 20 years of experience as a CFO, setting up the systems in order to be nimble in this future world. If you don't have the ability to calculate the data at the level you need to, and with the granularity that you need to, then you're going to be kind of lost when you go in to negotiate reimbursement. So this next session is very important. And it'll lead us into sessions 3 and 4. Next slide. So thank you very much for attending today. Bobby, do we have any questions that are kind of, you've been scanning the list there. We have almost no time.
Yeah, we can run through a couple of them. There's a couple of questions about, there's 2 or 3 questions that relate to, do you include front-end staff or in the direct support or overhead? Front-end registration people, registration, referrals people are all included in that direct support. If you go to the bulletin, the NAC bulletin, you can see that they list those positions. So yeah, the registration people, referrals people, all the people at the front end of the clinic would be included in direct support. There's one question about, would that include billing? No, billing would then be considered as an overhead cost. The billing departments in most places are separate, and that would be down in the overhead section, and billing would be then allocated out based to the clinics based on a percent of visits. Yeah, we do have some specific lists we can give, and what I can probably do is take a list of overhead costs that are being asked about and put them out here as an attachment at some point, so you can see that. And so someone asked a question about, does all this mean I have a PPS rate, I'm going to get a higher rate? It means that you need to know all this information to prove to the people setting the rates that you need a higher rate. So no, it doesn't guarantee it. What it does is it gives you the ammunition, if you will, to sit down with the people that are setting the rates. And some of the rate settings we've done based on fee for service, based on quality outcomes, and the quality outcomes, to address one of the other questions, are pretty much going to be driven by what the payers say they want the quality outcomes to be. You might have some negotiation points with them, but it's pretty much going to be set by, and has been set by, in my experience here, by what the payer says. The payer says, we want you to have these HEDIS measures and we want you to hit this number. That's what's in your contract. So you can have some negotiation to it, but pretty much the payers are going to tell you that. So I think those are the kind of the general answers to these questions. I think that in session 2, we would probably even be able to feel better about some of the answers I just gave you when you see some of the detail in session 2. But what I can do is go through these questions after the fact and put some answers out there for everyone to look at, if that makes sense.
And feel free to use the contact information you have there for me, and it'll get to Bob as well. And we can respond to you if you have a specific question for your specific situation. We're happy to do that. Okay.
Certainly will.
We've come
and
to our
thank you again, Jim, Dave, and Bob, for presenting. And after you close out the session, you will be directed to a very brief survey, and we really appreciate any feedback you're able to provide. And I'd like to thank you all again for joining us for today's presentation, and look forward for you to joining our future presentations and sessions.
Thanks, everybody.
Thank you.